I'd like to thank the Immune Deficiency Foundation for inviting me to speak today to you about APDS. Also, as a native Chicagoan, I'd like to welcome you all to the beautiful city of Chicago. You picked the perfect time to come visit. And before we jump into our talk today, I do want to share my top 3 recommendations for things to do when you're visiting Chicago. I highly recommend the River Architecture Tour, the Art Institute. You would be amazed by some of the pieces that they have there, and the Museum of Science and Industry, especially if some people have young children with them. You will really enjoy those 3 highlights. Also, as a disclosure, I have participated in a study by farming. So without further ado, I'll get started. So the objective of our talk today is to just have an entry-level discussion about APDS. And a lot of times there's a lot of confusion about APDS and how it's similar to CVID or different from CVID. So we'll talk a little bit about that. Next, I'll talk about tips and resources for managing an APDS diagnosis. And then lastly, we'll talk about the role of genetic testing. So APDS falls under a group of diagnoses that are called primary immune regulatory disorders. So this is a subset of primary immune deficiencies, and these are called PIRDs. And this is when a patient can have 2 different things going on. And the way that I explain it to patients in clinic is that there's an imbalance in the immune system. So some parts of the immune system are not working well. That might be the part that's supposed to help fight off infections. So that's where you have the immune deficiency piece, the predisposition to infections piece. And so that's one part of the imbalance. But at the same time, while you have a low functioning immune system, you can also have an abnormally working immune system where some immune responses are exaggerated, and that can result in things like autoimmunity, autoinflammation, and lymphoproliferation. We're starting to learn a lot more about this category of diseases, and APDS is one of those diseases that falls very neatly into this criteria. What happens under the category of PIRDs is, again, you not only just have infectious complications, lots of different other parts of the body may be affected. And I think what's really important to note is that the immune complications may not be the most apparent, but they may not present first. And that's why a big personal mission of mine is to educate my colleagues in all of these other specialties about the complications that can initially present, and then that patient may go on to develop the symptoms that are more characteristic of an immune deficiency. So, for example, patients may have unusual rashes, they can have lung complications, they can have cytopenias, meaning low blood counts. Very often we see the GI tract is involved, and patients can have things like inflammatory bowel disease. You can also have endocrine system involved, so you can have autoimmune thyroid disease or type 1 diabetes. And then less commonly, you can have neurologic or musculoskeletal manifestations. So the whole, what I'm trying to get across with this slide is that a lot of times when we think about immune deficiencies, the original thought process was the patient who was predisposed to infections. But now we're learning that all of these different organ systems can be involved. Sometimes that is the more dramatic, more serious presentation, and in many cases, that's one of the first presentations. So APDS is a PIRD where we have both immune deficiency and a predisposition to infections, but then you also have the immune dysregulation where you have autoimmune complications. And I think telling the story of APDS is really neat for me because I started my fellowship in 2013, and one of my mentors is actually in the back, Dr. Jennifer Puck. So when I first started training with her, neither one of us really knew what APDS was. The gene had been identified back in 2006, but we didn't know what this disease condition was. But in the 11 years since we've been able to identify this disease, we've come so long in terms of improving our understanding of diagnosis and treatment of this condition. And this also just gives a hope to a lot of patients that don't have a diagnosis. I think this condition just shows that with all the advances that are being made in the world of immunology, we're not that far away. So if you're someone who doesn't have a clear genetic diagnosis yet, that might change next year, that might change in the next 5 to 10 years. And with that genetic diagnosis, it's possible that other options, including treatment options, may be available to you. APDS is a rare condition. The estimated prevalence worldwide is 1 to 2 per million. But this is not unusual. Many of the diseases that you'll be hearing about over the next couple days are extremely rare conditions, but those of us that are affected by it or have a loved one that are affected by it can appreciate how impactful these rare diseases are. From an immunologic standpoint, we put APDS under a combined immune deficiency category. What that means is that both B and T cells are affected. And there's actually 2 types of APDS. There's APDS1 and APDS2. I will not go into the nitty-gritty details, but I just wanted to introduce that idea in case when you do some of your own reading, you might come across that terminology. And the difference between the 2 types of APDS has to do with the specific mutation and the specific genes. So APDS has a wide range of clinical manifestations. As I mentioned before, when there's a PIRD, you can have infectious complications, autoimmune complications. So APDS specifically also can have these different organ systems that are involved. And I would say almost all of the patients that I take care of with APDS have had the autoimmune complications present early. I've had patients who presented entirely with enteropathy, and then it took an astute GI doctor to refer them to me for additional evaluation. So some of the other organ systems that can be involved are you can have lymphoproliferation, which means that you can have abnormally enlarged lymph nodes, you can have enlarged spleen or enlarged liver. And there is also an increased risk of lymphoma as patients get older. We talked about the enteropathy. The cytopenias are a really big part of APDS. So patients can have autoimmune cytopenias. So that means that your body is making antibodies that are attacking its own blood cells. And so that can result in really low hemoglobin, low platelet counts, low neutrophil counts. And then there are some patients who have been described to have developmental delay associated with their APDS or failure to thrive. And then in terms of the infectious complications, so most patients with APDS will present with infectious complications before the age of 5. And what do these infections look like? For majority of patients, these are recurrent, severe sinopulmonary infections. These are frequent pneumonias, and it's thought that all of these recurrent infections lead to bronchiectasis, which is an issue with scarring of the lungs, and that itself can increase your risk for additional infections. So as I mentioned, you can have a lot of autoimmune and lymphoproliferative complications, but I don't mean to minimize the infectious complications either. Patients may require several rounds of antibiotics per year, and you'll really start to see this pattern very early on in childhood. And then there are some specific viruses that patients with APDS are at increased risk for, and so that includes things like EBV and CMV. So this slide shows that APDS can evolve over time and may be underdiagnosed, and this is because the picture changes. And so if someone is having a specific complication, they may be sent to a different doctor. So let's follow our hypothetical patient. We might have a young child who first presents with lots of infections, and at that time someone might say, oh, it's a young child, they're in daycare, they have older siblings, maybe this is why they're having lots of infections, and so they may not require, or they may not be sent to an immunologist. And then that patient might have some lymphoproliferation, meaning they might have some enlarged lymph nodes, they might have an enlarged spleen or liver, and if they're overall doing okay, perhaps that wouldn't prompt an evaluation either. As they get older, perhaps the enteropathy will set in, so the GI disease. They might have additional autoimmunity like the low blood counts or arthritis, and depending on what those symptoms are, that will prompt who this patient gets referred to. So if the GI symptoms are so severe, then that patient might just be referred to a GI specialist who's only going to look at them from their GI lens. So they're only looking at the GI tract. They're not going to go and ask about, what was the history of infections before the age of 2. They're not necessarily going to be looking at the lymph nodes. They're going to be specifically looking at the GI tract, and they'll be using therapies that are targeting the GI tract inflammation. Same with the cytopenias. If you have low counts, you might go see a hematologist, a specialist in blood disorders, and they might just be looking at that patient with the lens of, how do I fix these blood count numbers? How do I just get that hemoglobin count to go up? And so they'll be using the tools that are in their toolbox to fix that specific problem. And then if left undiagnosed, this patient all this time might still be having a lot of infections, might still be having, again, the ear infections, sinus infections, pneumonias, and because they haven't been diagnosed, because there's a diagnostic delay, by the time that they're 11 or 12, they might be developing bronchiectasis. And then as they progress, the risk for malignancy increases. So what this slide is showing is that you really need a physician or healthcare provider who's able to put these different pieces together, who's able to start all the way from the beginning and ask about infections, ask about lymphoproliferation, ask about autoimmunity, and try to tie all those 3 different things together with the hope of getting to a diagnosis. And then what this is showing is that the median age of diagnosis is 12 years, and there can be a 7-year diagnostic delay from when the symptoms first present. And all of us know that this is not unique just to APDS. Almost every other IEI or PID has a diagnostic delay because that presentation can be different and it can evolve over time. This is where taking a careful family history is really useful. This is where taking a comprehensive history is useful. This is where, as a healthcare provider, we really try to look at the patient as a whole instead of the separate organ systems. And the goal of early diagnosis and treatment is to interrupt the disease evolution. So we want to make the diagnosis, stop the progression of the disease, so we can prevent these more serious complications. So this is from a paper that was published last year. How do we improve early diagnosis of APDS? So the goal is that we can really increase awareness of this specific disease process. That means not just informing other immunologists, but really our other specialists as well, the lung doctors, the GI doctors, the hematologists, the pediatricians, any other healthcare provider that might be seeing these patients. And so what we try to do at our institution when we're trying to raise awareness for PIRDs, we really try to send home the message that if you have a patient who has increased susceptibility to infection, but then they also have autoimmunity or lymphoproliferation or there's developmental delay, then we really want the other providers to stop and think about, is there an overarching unifying diagnosis? For patients who have CVID-like disease or combined immune deficiency, we also want people to be thinking about APDS. So any of these scenarios would lead to genetic testing for APDS. So let's say that a patient has really bad bowel disease and the GI doctors get a history of, oh, there's also another family member who has bowel disease and has needed immunoglobulin replacement. So they take a good history and then they decide that this patient would benefit from seeing immunology. When they come into my clinic, what are the things that I'm looking for to help support a diagnosis of APDS? This is very specific, so I'm sorry if it gets a little nitty too much into the details, but some of the things that we know that patients with APDS have are lack of these naive B cells and a shift towards a different type of B cells called transitional B cells and plasma blasts. And the issue with this shift is that there's impaired class switch to IgG antibodies. We know that these IgG antibodies are very important for helping fight off infections, and so patients may have elevated IgM and they're not able to switch over to IgG. So some patients may actually be misclassified as having hyper IgM just because that IgM level is so high. And it's only with additional investigations that we can really clarify the diagnosis. In terms of the T cells, patients can have low CD4 positive T cells and normal or high CD8 positive T cells, and then they can have low naive T cell counts. Many of you are aware that as immunologists, we check for vaccine responses. It helps us understand if patients have an ability to mount memory responses, and we actually look for two different pathways. So in APDS, there's a T cell independent pathway when we're looking at things like pneumovax responses, and that can be affected. So patients will have poor specific antibody responses. And then again, when I see patients where I'm concerned about APDS, I'll ask about, did you have infections starting before the age of 5? Were they mainly sinopulmonary? And then I'll always ask about history of infections or complications with infections such as EBV and CMV. So you'll note that a lot of the immunologic discrepancies that you see in APDS that overlaps with CVID. So it is common for patients with APDS to be initially diagnosed with CVID. CVID is kind of just our overarching umbrella diagnosis. So many patients with APDS may be categorized under that diagnosis and may remain in that category unless someone does additional testing, specifically genetic testing, to kind of sort them out to a more specific diagnosis. So we always teach our fellows that getting a good family history is really important, and APDS is one of those diseases where we do see increased prevalence in different family members. So if we identify one patient with APDS, we do recommend testing family members. In a review of APDS, nearly 40% of patients had a family history, and so this can be very useful in diagnosis. One thing I do want to mention is that symptoms frequently do not present in the same manner within a family. So one family member may have more of the infectious complications, another family member may have more of the autoimmune complications. So it might not look the same, and that's why it takes an astute clinician to be able to identify that there's some type of immune dysregulation happening within a specific family, but it can look a little bit different. So if you have a family where the father is affected, the mother is unaffected, there is a 50% chance of APDS being passed down to the patient's children. So it's really important to be able to make a diagnosis so patients can have a better understanding of what the risk is that they may pass the disease on to future offspring. So genetic testing is important because the definitive diagnosis may change treatment. So at our institution, especially because I mainly take care of pediatric patients, their presentation usually ends up being a lot more dramatic. They're a lot sicker. They can have a lot of different organ involvement, so I tend to do a lot of genetic testing. And sometimes I get asked by colleagues or insurance companies, why do we need to do genetic testing? What's the benefit? How is it going to change anything? Why does it matter if an APDS patient is categorized as CVID? Aren't you just going to do the same thing? Don't they just end up on immunoglobulin replacement? Don't you just treat the infections? Why do we need to go the extra mile to make that specific diagnosis? And the reason is because it can significantly change treatment, and it also helps us prognosticate what kind of other complications that patient may have. So in a patient with CVID, maybe my concern for lymphoma is not going to be as drastically high, but in a patient with APDS, that is something that I'm constantly monitoring for. So not only does it affect treatment choices, it also helps us look ahead to what type of complications we need to be screening for. One of the issues that I have, one of the hardest parts about taking care of patients with immune deficiency is I feel like we're always we're reactive, not proactive. We are always having to handle issues that have already happened. So, okay, the patient already developed cytopenia, they already had these infections, but it's so nice with the advent of genetic testing to be able to look forward and anticipate and hopefully prevent complications. So that's why we, in the immunology world, the role of genetic testing has just become so central. So Pharming does have a partnership. They are changing the workflow, but there is a free genetic test that is no cost to qualified patients. We get results pretty quickly, and I've personally used this workflow, and it works quite well. It's easy both for the patients and the providers, and then there is free genetic testing for family members, because as mentioned, there is a higher risk of family members being affected. So in regards to the treatment, as mentioned, until 2013, until we had increased awareness of what this disease process was, many of these patients were under the CVID umbrella. So the way that we took care of them was, again, the immunoglobulin replacement, antimicrobial prophylaxis, treating the immune dysregulation with things like steroids, rituximab, and then things like mTOR inhibitors, so the names you may be familiar with are rapamycin or sirolimus. So you're kind of doing both things. On one side, you're trying to boost the immune system with immunoglobulin replacement, trying to prevent infections with the prophylaxis, but then at the same time, you're trying to dampen down some of these abnormal immune responses by using steroids and other immunomodulators. There have been some stem cell transplants that have been performed on patients with APDS, but there have been complications such as GVHD or issues with engraftment, so that's currently not standard of care. The other problem is that we know that patients can have a different phenotype, so some patients with APDS can be mildly affected and some can have a more severe presentation, so it seems a little risky before you know how severely affected that patient will be to send them to transplant. So as mentioned before, we had these treatment options in our toolbox, but now we have a new therapy. It's called leniolisib, which is a poster child for precision medicine. So I'm sure you've all heard of precision medicine. The whole point of precision medicine is that we don't use a one-size-fits-all approach to treatment of patients. We're able to tailor our treatment based on that particular patient, specifically in regards to their genetic diagnosis. And so instead of kind of just, again, using what I like to call Band-Aid approach, you try to get to the bottom of the issue, so what's causing this immune dysregulation, and then you try to correct that. So the way that I think about APDS is I think about it as a light switch that's turned on, and it just stays turned on. And we all know sometimes the light switch should be on, but sometimes it needs to be turned off. And in APDS, that switch is always on, so you have a revved up immune system that's causing all of this dysregulation. that's resulting in the autoimmunity and the lymphoproliferation. And when that immune system is so revved up, it's not able to actually do what it needs to in terms of fighting infections. So what if we had a drug that could turn off the switch so that you could restore balance? And so that's what leniolisib does. It allows for there to be a more regulated immune system where you don't have this hyper-exaggerated response. And so there was a phase 3 clinical trial that looked at APDS patients over the age of 12, and it looked at them over 12 weeks, which actually is not a long period of time. These patients received 70 milligrams of leniolisib twice a day. So there were 21 patients on the treatment arm, 10 patients on the placebo arm. And within those 12 weeks, they noticed that the naive B cells, which are usually low in patients with APDS, those numbers came up. That hyper IgM type picture resolved, so the IgM came down, and there was class switching over to IgG. When I look at these papers, I love looking at the pictures of just how dramatic the decrease in the splenomegaly is and the lymph node enlargement is. So even within 12 weeks, you could see that the spleen size came down. Patients had improvement in their cytopenias. And as a clinician, what's important for me to note is that there is, it's a very safe drug. It was well tolerated. And some of the side effects that were reported are not unlike the side effects that we notice with other drugs. So this is a really exciting story because, again, we're moving away from this one-size-fits-all approach. We're going to handle the issues as they come up. So if a patient has low IgG, we're going to give them IVIG. If they have hemolytic anemia, we're going to throw some steroids or rituximab at them. Instead of that approach, we have an approach where we're really looking to see what are the immune defects and how can we correct that underlying immune defect. So I like to think of the APDS story as the dawn of a new era in the world of immune deficiencies. As a clinician, if someone asked me what is my wish list, well, number one wish would be for my patients to not have these diseases, for these diseases to just disappear. But if that's not the case, what I really hope for each patient that I see is early diagnosis. And with the advent of genetic testing, with us being able to identify the gene and have easy and affordable access to genetic testing, we are a step closer to early diagnosis. And then the diagnosis and the knowledge of the mutation has led to the development and approval of a drug within 10, 11 years, which is remarkable. And this drug is safe, it's tolerated, and it's targeted. So again, it's not like a blanketed approach, and it's not immunosuppressing the patient, but it's a targeted approach. And I think this really shows the beauty of our field, of where immunology is going, where we're able to utilize the advances, our knowledge of the advances in immunology, and use that to better the lives of our patients. So I'm really excited to see how other disease processes follow this same path. But it's really wonderful to be able to come up here and tell the story of APDS and offer hope to patients. So thank you.
All right, thank you so much, Dr. Ahmed. That was wonderful. We are going to get ready to transition to a brief Q&A, but before we do, I'm going to share a couple of IDF resources. If you leave here today with any lingering or unanswered questions, please visit our Ask IDF resource. A member of our team will reach out to you directly to provide support or connect you to the appropriate resource. We can also help you connect with others in the PI community through our virtual Get Connected groups. IDF Get Connected groups offer individuals diagnosed with PI and their family members the opportunity to connect, share experiences, and receive support in their local communities. Finally, please remember to complete your session survey through the conference app and let us know how you enjoyed this session. All right, we now have time for a brief Q&A. If you have a question, please raise your hand. I have to grab the mic from the back of the room, but I will walk it over to you, and you are free to ask your question. So give me just a moment while I grab the mic. And if you want to come back up or sit, either one. Come. All right, I think this is on. Okay, does anyone have a question?
So thank you very much. I really appreciate it. Very informative. What was most exciting to me was this fact of the collaboration of farming partnerships with Invitae and that process of genetic testing. Could you talk just a little bit more about that, and how do we get that information out? And is everybody doing it, or is it just how's that being done? Because that seems very promising.
Yeah, and I would say that that is not a unique scenario. What I'm seeing in the clinical immunology world is that we are seeing, as we have more and more targeted therapies that are emerging. So for example, for WHIM syndrome, we just had a therapy that was approved about 6 weeks ago. And so there's a similar type collaboration. So I think this isn't unique to this disease process. And I hope that moving forward, we'll see similar partnerships. As a clinician, getting genetic testing covered by insurance is very, very challenging. Thankfully, there are lots of other resources. So I haven't had to turn away a patient from genetic testing due to lack of resources, but I know that there can be a lot of obstacles. So I'm particularly appreciative of these collaborations. In terms of the workflow, I think the folks at Farming have been trying to increase that awareness and talking to other providers just to make that pathway a little bit easier. I think, again, it's really important not just to talk to the immunologist, but maybe to talk to the GI doctor or the hematologist who might be seeing those patients and clearing that path. Does that answer your question? And I know we have our folks from Farming here who would be happy to chat more with you afterwards.
Thank you, Dr. Ahmed.
You spoke about that you primarily treat pediatrics, and the drug and all the research I've seen has indicated age 12 and up. Have you treated any patients younger than that with APDS that has taken this drug?
That's a great question. So I personally have not treated anyone younger than age 12. I know that there are trials looking at ages less than 12. So my hope is that the drug will be available for the lower age indications in the near future.
Wonderful, thank you.
Hi, so as a patient, I'm a mother of a patient with APDS. I have been wondering what other kinds of diagnoses this medication might ultimately be indicated for, just given how rare the patient population is, the long-term availability of it.
That's a great question. So are you asking, would it be applicable to other immune deficiencies or even more broadly speaking? Either. Yeah, so I think, so actually my husband is an oncologist and he knew about this drug before I did because these group of medications have been used for treatment of other hematologic malignancies. So, and from my understanding, I think this actually came to be because this is a rare immune deficiency, but the hematologic malignancies, there's a lot more patients, so there's a lot more funding for development of those drugs. But we already talked about the collaboration between the specific drug developers and genetic testing. There's also collaboration between different specialties where someone says, hey, look, in the oncology world, there's this disease or this medication for a somewhat common disease process. I wonder if I can use it for my patients with an uncommon disease process. So this again just speaks to that collaboration. So to my understanding, that's kind of what the broader application for this specific drug would be. You bring up a good point, which I haven't really seen a lot of discussions about whether this specific therapy would apply to other patients with other immune dysregulatory conditions. Sometimes we can use drugs that turn off a specific immune pathway, even if it's not associated with that particular pathway. Let's say it might be upstream or downstream, but I'm not aware of any other indications or anything in the works for expanding the indication.
Is there something specific about the pathophysiology of APDS that makes it more likely that a graft would fail in a transplant? And then I guess to piggyback off of that, do you ever still have patients with such severe presentations of APDS where you do still send them to transplant?
It's a great question, asked like a true hemonc nurse. So in terms of issues for graft failure, I'm not well, we do know that in general, PERDs are harder to transplant. That's because you're going into transplant with a lot of inflammation, and so that can be part of it. And then in terms of, I have not had to send a patient with APDS to transplant. The hope is with the newer therapy available, we're able to manage all of these different complications. It's also new, so we don't really have long-term data, but the goal and the hope is to prevent having to send a patient to transplant.
Thank you, Dr. Ahmed. Any other questions from our audience?
Sorry, a little follow-up on the transplant question, especially for a younger patient who maybe didn't have a lot of complications yet, and knowing that the risk of cancer is the main and growing risk throughout their life. If they had a really good candidate for a transplant match, would that, it's seeming like you're not really considering that anything but a last-ditch therapy, but if all the stars were aligning, could that perhaps set them up for a better course long-term?
That's a great question. So, and this is a question that kind of expands beyond APDS. There are lots of discussions in the clinical immunology world about if a patient is doing well at present, let's say they have a genetic diagnosis, they're doing well at present, shouldn't that be the best time to intervene with an intervention like stem cell, as opposed to waiting for them to get so sick, develop the autoimmunity, which then will lead to poor outcomes with the transplant? So that's always a consideration that I have as a clinician. There is a thought, though, that with this therapy, if we're controlling the lymphoproliferation and we're controlling the splenomegaly, the hepatomegaly, there is hope that perhaps that will lead to lower risk of lymphoma. The drug has only been out for so long, so we don't have that longitudinal data, but there is a thought process that if we're able to control that unchecked lymphoproliferation, perhaps that will pan out to the decreased risk of lymphoma specifically.
All right, well, thank you so much, everyone. That about brings us to the end of our session today. I just want to again thank Dr. Ahmed so much for her wonderful presentation. Thank you to Farming for supporting this session, and thank you so much to our audience members for your thoughtful questions. We really appreciate it. We hope you enjoy the rest of the PI conference, and we look forward to seeing you at the next session at 11:15. Thank you so much.